Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to our 4th annual National General Medical Oncology Summit. We have a great faculty today and this entire weekend, and we also have for each one of the sessions today and tomorrow a co-moderator on the stage with me from the Florida Cancer Specialists. This morning we have Mayan Hussein, and you can see we have a bunch of other people coming up today and also tomorrow. Here are the faculty that we're going to be working with today. And here's a photo of the faculty that we'll be working with the whole weekend. You know, last year, one of my quirks is I like to put together people asking me about good questions. So we're going to show you, these are just comments we've heard in the past year. We'll show this throughout the weekend from some of our faculty.
Good questions. Lots of great questions.
That's a great question.
It's a great question.
These are very good questions.
It's an excellent question.
That's a great question.
Well, that's a great question.
I think it's a fantastic question.
That's a really good question.
That's a really important question. This is such a great question.
Those are all really good questions.
That's a great question.
That's such a great question.
That's a very, very good question to ask.
I think that's an excellent question.
That's a great question.
I think this is a really important question.
This is a great question.
That's a great question.
That's a great question.
So Mayan, that's your challenge today, is to make them say that's a great question. So before we get started, let me introduce the president and the head of the FCS, Dr. Lucio Gordon. Lucio?
Thank you, Neil. Good morning, everyone, and great question. I'm glad we have quite a good number of attendees here already, and I'm sure a lot on video. Thank you, Neil, for your graciousness with all your time and expertise, and the panelists and the moderators of FCS. Look forward to a great day with a lot of good exchanges and questions, and great questions. And please feel free to connect with us after the meeting and with the moderators as well. Happy to continue this multi-year or almost multi-decade relationship with Neil Love and Research to Practice. So thank you, RTP, and everybody, great day.
Thanks a lot, Lucio. So we're going to move on now and talk about breast cancer. We have the same team we had here last night, Dr. Joyce O'Shaughnessy, Dr. Aditya Bardia, Dr. Ginger Borges, and Dr. Hal Burstein. And you can see the topics last night. We talk about metastatic ER-positive disease, and we'll talk about everything else in breast cancer today. Also, when we get into ER-positive, we brought up last night this press release that just came out of the so-called SERENA-6 study that's really going to change I think at some point change the management of metastatic ER-positive disease. For those of you who weren't here last night, we're going to just mention it briefly as we go through today. So we're going to start out talking about HER2-positive breast cancer. Joyce is going to review some of the relevant data, and then we'll sort of jump in with some cases and questions. So Joyce?
Okay, good morning, everybody. Thanks a lot for having me here this time. Here's my disclosures. So we're going to just reflect for a moment about the fact that in HER2-positive breast cancer for stage 2 and stage 3 disease, we provide preoperative therapy. And if you look at the Trifina data with the preoperative TCHP, we see a PAF-CR rate of 63.6%, and then the FEC followed by THP about 55%. THP times 4 pre-op about 39%. So as you know, we've really picked up the TCHP mainly in this country, but there are patients who don't get a PAF-CR, of course, and we're very happy to see these really phenomenal data at the 8-year follow-up mark with the Catherine bringing in TDM1 versus trastuzumab in patients who did not have a PAF-CR, and seeing an absolute improvement in IDFS of 13.7%, really, really huge. We very rarely see curves that far apart in the curative setting, as well as about a 4.5% improvement in overall survival that was also significant. So a lot of progress there. We still see 20% of patients have had an IDFS event at the 7-year mark. So still room for improvement. One area that is controversial is, what about those T1C and 0 patients clinically? Should they get preoperative therapy or should they go to surgery first? And you can see in the red box down the bottom, this is a series from Dana-Farber, And in the T1C clinically N0 patients, about 24.7% when they actually went to surgery first ended up having nodes involved. And that's really important because they've had node-positive disease. We'd like to give them preoperative TCHP. So that might be an argument to give neoadjuvant therapy first. But we also know the T1C N0 patients with, if they go to surgery first and they get paclitaxel trastuzumab, they do great. They're really, really great. So there's this balance of not wanting to overtreat and find out they're not PAF CRs if we give them a preoperative therapy and then they go on to TDM1. Do they really need that? So the Dana-Farber his approach is to do ultrasound, actually ultrasound of these T1C N0 patients, and then biopsy anything suspicious at all. And of course, if it's node positive, they get treated as such. And if node negative, consider going to surgery. It's an interesting question. I think that's a very, very good algorithm, as a matter of fact. But we still have that problem that I showed you on the Catherine trial. At 7 years, 20% of patients have still had a recurrence or death from their breast cancer. And there's another option we can offer patients that are HR positive and HER2 positive, and that's oral neratinib, the pan-HER family inhibitor, which is FDA approved for extended adjuvant therapy of early stage HR positive, HER2 positive breast cancer who have finished their adjuvant trastuzumab within a year, who have been treated with neratinib within a year of finishing their adjuvant trastuzumab. And in the ExteNet study, this trial was done before we had pertuzumab and before we had TDM1 as standard systemic therapies. And these patients finished up their trastuzumab, and then they were randomized to 1 year of neratinib versus placebo. And the primary endpoint actually was 2-year IDFS. But if we look at the 295 patients in ExteNet who received preoperative chemotherapy and trastuzumab and then finished up their trastuzumab, and they did not have a PAF CR, and these are the patients in practice that we would be thinking of considering neratinib for, we can see an absolute improvement in IDFS at 5 years of 7.4% and an absolute improvement in OS of 9.1%. And these are both significant, although this is a exploratory analysis, a post hoc analysis. So this shows us that the neratinib is non-cross resistant between chemotherapy and trastuzumab. We don't have level 1 evidence that it's non-cross resistant between trastuzumab, pertuzumab, and TDM1. But this is, of course, a tyrosine kinase inhibitor with a totally different mechanism of action than our antibody-based therapy. The other thing that's important about the neratinib is that it does reduce the risk of having a first site of metastasis, of a brain metastasis. You can see in all patients it's about 2.1% with placebo, 0.7% with neratinib. Then down the bottom, patients who did not get a PAF CR, 3.6% first recurrence in the brain with placebo, and 0.8% with the neratinib. So a decrease in the risk of the brain as a site of first metastasis. And that's different than in ALTO. Lapatinib did not decrease brain recurrence risk. Pertuzumab did not. And also the most recent data from Catherine down the bottom there, there's no decrease in brain metastasis with TDM1, unfortunately. So that's clearly an advantage for patients with neratinib. Now, of course, diarrhea is the main toxicity of neratinib, and we can see down the bottom left here that we would like to start with 3 pills daily, and then after a week or 2 go to 4, and then either skip to 6 or go up to 5. And with that, only 3.3% of patients discontinued the 1 year of neratinib in the control trial with loperamide plus neratinib dose escalation. And then in the minority of patients who needed something else, you could bring in cholesterol. So there's a very nice algorithm now worked out to minimize diarrhea and try to keep patients on the highest dose they can tolerate of the neratinib for a total of 1 year. And so this algorithm in the early stage setting, if we start here on the top right, if they're stage 2 or 3, they get preoperative TCHP, and if they are not a PAF CR, it's TDM1. And then if they still had node positive disease or a very large cancer that's HR positive, still a considerable amount of risk, neratinib is an excellent therapy along with endocrine therapy for those patients. And then if they have a PAF CR, they finish up their HP. And then if they're a centimeter or less, T1A or T1B, they go to surgery first. If they're stage 1, they get TH, or if they have a history of neuropathy, perhaps TDM1. And if they turn out to be stage 2, 3, they can get TCHP if they have node-positive disease, or TCH if they have node-negative disease. And then if they're T1C and 0, the axillary ultrasound can really help put them into, if they're positive on node biopsy or clinically node-positive TCHP, and if they're negative, go to surgery first. So I think that's a very reasonable algorithm for our early-stage patients. So I think one of the two most important data sets in breast cancer from San Antonio this year was this Patina trial, a global trial actually run from the Dana-Farber, Otto Metzger. And this was for patients in the first-line metastatic HER2-positive setting. And these patients had 6 to 8 cycles of treatment with trastuzumab, with or without pertuzumab, but 97% had pertuzumab. And then if they had a CR, PR, or stable disease, then they were ready for their maintenance therapy. They were randomized to trastuzumab plus minus pertuzumab with endocrine therapy versus with the addition of full-dose palbociclib. And the response rate with the chemotherapy, the taxane, trastuzumab, pertuzumab, was 69%, and 71% of these patients had prior trastuzumab in the curative setting. So this was a question of bringing in palbociclib into an HR-positive, HER2-positive group of patients. And we can see a very large improvement here, a 15-month improvement in progression-free survival in the metastatic setting. We see median PFS up to 44%, and this is high in these patients with HP and endocrine therapy because, of course, it's enriched for the patients who did well with the taxane, trastuzumab, and pertuzumab. But this is really a very important result that I think will change practice. I think it already has started changing practice in several patients I've seen since this time. So that, I think, is a new approach to first-line treatment. In the second-line treatment, the TDXD in the DESTINY-Breast03 was substantially superior, both with regard to progression-free and overall survival compared to TDM1 here in gray. And these are brain metastasis at baseline, no brain metastasis at baseline. So you can see, regardless, there's a huge improvement in progression-free survival and a large improvement in overall survival as well, making this the really established second-line regimen in the metastatic setting. But brain metastasis is a big issue, as we know. If patients live long enough, about half of them over time, and it's just cumulative, it just keeps going up, will develop brain metastasis. And at any one time, as we go from room to room, about 25% of our patients will have occult brain metastasis. If we're not looking for them, they will have occult brain metastasis. And we do know that if patients do have brain metastasis, the HER2 CLIMB regimen of tucatinib, capecitabine, and trastuzumab has a very large improvement in CNS PFS here. At 1 year, none of the patients on trastuzumab and capecitabine was progression-free in their brain versus 40% for patients with the addition of the tucatinib. And here's the median CNS PFS here. So big improvement here in the control of brain metastasis. Importantly, of course, survival. We can see their 1-year survival here, adding the tucatinib in patients with brain metastasis. Active brain mets, about almost a 9-month improvement in overall survival in patients with active brain metastasis. So this is obviously a really big step forward for our patients with brain mets, and the response rate in the CNS is 47% with the tucatinib triplet. We saw data from ESMO this year, the DESTINY-Breast12 trial. This is single agent, single arm TDXD in patients with brain metastasis, looking at the 138 patients with measurable CNS disease at baseline. We see a very impressive degree of cytoreduction for these patients, with a response rate in all patients of 71%. And in the active brain metastasis, we see untreated active brain mets, a response rate of 82%, and 50% in previously treated active brain metastasis. So this is a very impressive degree of CNS activity with the TDXD. And so because we need additional progress in the curative setting, both the tucatinib combined with TDM1 in the COMPASS HER2 trial has been brought in for patients who do not have a PathCR, randomized to TDM1 plus minus tucatinib. Very important to see if we can make additional progress and decrease brain metastasis. And then the DESTINY-Breast05 trial. These are for patients who still have node-positive disease. They get preoperative chemotherapy trastuzumab and pertuzumab, and if they have residual node-positive disease, they're randomized to TDXD versus TDM1, and these data may be available later this year. I just wanted to finish with one other option for patients with brain metastasis, because some of these patients do live a long time, and that's the combination of neratinib plus capecitabine in this cohort of 49 patients from the TBCRC 022. And what you can see here in the lapatinib naive patients, a very good level of cytoreduction. This is in the brain now. And then even in lapatinib exposed patients. And so if patients have been previously treated with tucatinib, it's interesting to think that they still may benefit from neratinib, a broader spectrum anti-HER2 directed therapy with capecitabine. So another good option for patients with metastatic disease in the brain. So in summary, neoadjuvant therapy is the mainstay for stage 2-3 disease. And for T1CN0 patients, it may be reasonable in a cohort of them as well. TDM1 improves overall survival post-neoadjuvant therapy with residual disease. Neratinib for HR-positive patients with residual disease at high risk of recurrence. Palbociclib maintenance per the Patina trial, 15-month improvement in PFS. TDXD improves survival in second-line setting and has a high degree of CNS activity. The HER2 Climb tucatinib improves survival in the intent to treat and the brain mets populations. And later line neratinib cape is an important option for patients as well with brain metastasis. And then the Compass RD and DB05 are evaluating tucatinib and TDXD in early stage patients to reduce the risk for recurrence as well as the risk of a CNS metastasis.
So a couple questions, and then Mayan has a case that I'd like to present to Ginger, actually a current case, and you'll get 4 quick second opinions. But first, it's amazing. I was going through the slides we're going to go through today, and there's so many things happened in the last couple months, not just with San Antonio, but in oncology. I don't know if it's the end of the year or just if you take any 2 months of the year, things are happening in oncology. But how this Patina study, to me, is one of the amazing study. Maybe I always wondered about hormonal therapy and hormone receptor positive in HER2 positive disease. Actually, in the chat room, Shobha, and we had almost 400 oncologists online last night, says, what about the Patina strategy in the adjuvant setting? And maybe you can just comment in general about what you think this means right now and to the future in terms of endocrine therapy in HER2 positive disease.
Well, it's a very nice study led by Otto Metzger, and I think there are a couple of really important takeaways from the Patina study. One of them is it nicely separates the difference between how clinical trials for registration are structured versus how we actually take care of patients in the real world. So remember, in Patina, patients got about 6 cycles of induction therapy with THP. In the clinical trials, like the Cleopatra study or in the anticipated Destiny Breast 09 study, which compares THP versus TDXD, those patients are treated with the chemotherapy cocktail or the ADC until progression. But in the real world, what we all know we do is we give about 6 cycles of induction. There's almost always a great response. And then you run with the maintenance therapy because it's a lot less toxic. And in the case of ER-positive, HER2-positive disease, we also throw in a little bit of endocrine therapy. There are exactly 0 randomized trials that look at that question, but we all do it every day. And the point is that is what we should be doing. It's really important to understand that clinical trials for registrational purposes are not designed to necessarily inform practice in the same way that you think about it. So what Patina was excited about was it explored the opportunity to use a CDK4/6 inhibitor in a similar setting. When the first work at UCLA with Dennis Slayman was done on CDK4/6 inhibitors, they showed that actually CDK4/6 inhibitors are very active in HER2-positive disease. But all the commercial development was done in ER-positive disease because the feeling at the corporate level was that HER2-positive was sort of a saturated space. And so now what we're coming back to is this idea that if you add more effective endocrine control and anti-HER2 control at the same time, you're extending by about 1.5 years the time until a patient has to reinstitute chemotherapy. So I think that's a really valuable clinical improvement. And again, I would encourage you to remember this study when you see the results of the DB09, which will be reported at some point in the next year or so, I anticipate, because that'll be The paradigm should be the patina paradigm. You can choose whichever drug set as the winner there, but you're going to still do this induction and then maintenance phase. And if the tumor is ER positive, you'll add in endocrine therapy and likely a CDK4/6 inhibitor as well. As to the adjuvant use, I wouldn't do it. There are no data for it. The outcomes for HER2-positive disease, whether it's neoadjuvant, adjuvant, or neoadjuvant with salvage therapy on the back, are so good at this point, it is hard to imagine that additional therapy is clinically indicated.
So, Aditya, a lot of people are predicting that this TB09, looking at first-line TDXD, is going to be a positive trial. If it is, how long are you going to use the TDXD?
That's a good question. So, as per DB09, you'll have to use TDXD till disease progression. But as Hal was saying, you can make a case where you use 6 to 8 cycles, and then after that, transition to HP. And for ER-positive disease, you can add a CDK4/6 inhibitor as well. So we would need data to prove that this is a good strategy. But I think clinically, this makes a lot of sense because ADCs essentially are chemotherapy. So with TDXD, you're replacing THP. And then when you go to HP after TDXD, you should be able to transition to that.
So CDK or Palbo? I think Palbo was what was used actually in the Patina study. Are you going to go to your favored, we talked about this last night, CDK inhibitor, Aditya, or Palbo?
Palbociclib, because we have data with Patina. So till we get data with Ribo or Abema from other studies, clinically I would feel very comfortable with Palbo.
All right, Mayan, Ginger's going to help you out with your 56-year-old lady. Can you talk about what happened there?
Yeah, this is a very nice 56-year-old lady. She actually presented with stage 4. She had a left breast mass, and we did staging workup. Unfortunately, clinically, she did have axillary lymph nodes, but then the workup showed like bone and liver mets. So I did treat her with a combination of pertuzumab and trastuzumab and with chemotherapy. And I did actually 6 cycles of chemo. She had great response. So I put her on maintenance. She was ER/PR positive, so I added an AI. I added an anastrozole. And her quality of life improved, went back to work. She was doing great. But then early this year, her tumor marker started going up, and then she started feeling that breast lump is kind of growing again. The markers didn't jump sky high, but they were like, maybe 1 to 2 points. Clinically, we're still doing fine, except for just worried, of course, because that breast mass is coming back. So my great question. I ordered a PET scan just to see if she has disease in other areas. So my question is, if this is the only side of disease, would I rebiopsy to see if the biology have changed? Is that like a possibility? The other question is, she's on AI, and now with the Patina, like I could add a CKD, but should I also do a garden or like a liquid biopsy to see if she has ESR1? And is that a possibility to like switch from an AI before I add CKD, or should I try? So I know too many questions, but she's young, she's still functioning. I want to try to maintain quality of life and at the same time, try to control her disease.
Ginger, any thoughts?
Just to make sure I understand you. So she is progressing in the primary, but her
primary,
metastatic disease is still stable.
Still, I ordered a PET scan. I don't have actually the results yet, but so far no signs of recurrence. So the last scan didn't show any signs of recurrence in other sites.
So I think you could adopt the Patina results, although that is not exactly the patient for whom the Patina study enrolled, and consider adding in a CDK4/6 if you are not seeing a lot of progression in her systemic disease. If she does have global progression, then it really would be time to go on to a second-line regimen, which the standard there would be TDXD. If she has global progression in her systemic disease, I would get a brain MRI because, as you saw from Joyce, the occult metastases there often show up, particularly in younger patients. I don't tend to get a lot of mileage out of the ctDNA or the liquid biopsies in the HER2-positive space because we have a fairly secure track of what we are going to offer these patients based on the available clinical trial data. So I don't tend to do that till somebody is pretty far down their treatment pathline, and I'm wondering, could they possibly be cloning out an ERB mutation where then they would be a good candidate for neratinib as opposed to a different HER2 cocktail. I've had a patient do that over time. So I think wait for the PET scan, and if she's fully progressed, cross over to second-line therapy. If she's really got stable systemic disease and you're worried about her breast, you could contemplate doing something locally, although we don't tend to see a lot of mileage out of that. You could also give her the benefit of the patina results that came out after she had that opportunity in the beginning of her treatment and embark on it now.
All right, well, a couple of questions that I was thinking about. I wanted to get some input in on Joyce. So this is something we've been asking for the last few years. I'm starting to see new answers to this question. The patient who has a progression on first-line therapy now has brain mets. So second-line therapy, we got the HER2 data came out, everybody's all excited about that because of the activity in the brain. Then we started to see benefit, as you just described, with TDXD in the brain, Joyce. So in general, what are you doing in the second line in somebody who has CNS mets, HER2 or TDXD?
Historically, I've done the tucatinib triplet. I have a very similar, you showed solitary liver met, went into a prompt PAF CR and stayed there on the TH, and then all of a sudden here comes brain mets. Everything else perfect. And I actually chose the tucatinib triplet for her. That's really before we had the TDXD data, but she had one resected. They were both SRS, so now she's NED in the brain. And so she may be going a long time. And so I have leaned towards the TKIs because I've had good success with capecitabine and other, like lapatinib over the years. I have gals on that for decades, with actually brain mets. So I have tended towards the oral therapies for these patients who may be on it a long time. Now, conversely, if there was more brain metastasis than I could encompass with, she only had 2, this gal I'm talking about, then I would probably lean towards the TDXD if there was more bulky brain disease.
So Hal, last night we were showing, I'm going to show some more, some of these diagrams we do where we ask 20 investigators what they do, and that's our way of sort of taking the pulse of what's going on. And that's what I've been seeing change with this question towards TDXD as we've seen, greater activity in the brain, and also because people are more comfortable with supportive care with TDXD. How do you think it through?
Yeah, well, there are a couple of really important developments here. The first is that as the drug therapy has gotten better, we're seeing response rates on the order of 50 or 60% in the CNS. And I think it's really important to remember that because it turns out that the best way to develop drugs for brain metastases is just to have better drugs. There's no unique drug that works in the brain and not elsewhere or vice versa. It's just having better drugs. And when we had better drugs, we now have activity. That's true for lung cancer if you look at the ALK inhibitors and all that kind of stuff as well. The second thing is that there's so many options in HER2-positive metastatic disease that patients are living a long time, even with brain metastases. And so people have gotten very concerned about the late effects of whole brain radiation, including encephalomalacia or cognitive issues. So in someone who has minimal symptomatology like this, we would almost certainly go with a systemic drug choice. If they've not had TDXD, that's probably our first choice. And we would then see in serial imaging what happened. And our group has become very aggressive about going after specific recalcitrant foci with focal radiation or gamma knife for stereotactic therapy. Obviously, this is different from someone who presents with mass effect or significant compromise neurologically where they need neurosurgical decompression or urgent focal radiation. But it's really been a transformation because of better drugs for systemic therapy that also happen to work in the brain. And so now we're seeing the chance to spare patients more local therapy in the CNS.
Yeah, it's interesting. You just answered the top question I was about to ask. And
it was a great question, Neil.
But, it's almost starting to sound like we're going to talk this afternoon about patients with EGFR mutant lung cancer where they hold off on the radiation, give the osimertinib, et cetera. And it seems like that kind of strategy is being adapted. Another thing I've been hearing recently, Ginger, relates to symptomatic management of patients on TDXD, particularly related to nausea and vomiting. I'm hearing people talk more about olanzapine with TDXD. Can you talk about how you integrate that agent into management of these patients?
Sure. So olanzapine had data for its positive benefit in anti-emetic medication regimens quite some years ago now. So it's become standard at my institution for anything that's highly emetogenic. So the ACs, et cetera. And TDXD is in my mind a pretty interesting drug because some patients tolerate it great and some don't. So we do often start with the heavier antiemetics to begin with, and then if somebody is doing okay, back down on that. You have to clarify for patients what the purpose of olanzapine is, because if they go looking it up on the internet and they see the the original use for it in mental health, they get a little worried. But we reassure them that that's not why they're getting it, and it can make a big difference for many patients.
So one final point, and again, makes me think a little, getting back to this issue of endocrine therapy and HER2-positive disease, Joyce. I think about neratinib, and you were talking about the fact you see so much more benefit with ER-positive. I don't know if anybody's ever explained it, but this is, again, more phenomenological. This is a poster we did at the San Antonio meeting. It was interesting. We had previously done a very similar survey, HER2-positive localized disease in 2018, our typical thing with 25 investigators. So we went back to pretty much same investigators 6 years later to see what they were doing. And of course, it was just pretty interesting. So first of all, in terms of just kind of almost a historical thing related to what Joyce was talking about. So 2018, if a patient had neoadjuvant therapy with HER2-positive disease, path-CR, they got either trastuzumab or TP. By 2024, that had solidified to trastuzumab, pertuzumab. But whether it was ER-positive or not. But then what was even more interesting was patients who had residual disease, and of course you see a complete flip. It happened instantaneously when the Catherine data were presented as continued to TDM1. This is an ER negative where you see no neratinib, and then when we say ER positive with minimal residual, you see quite a few people saying they would use neratinib, but not quite a few who don't. Then we say, well, what about it was macroscopic, or even more? And again, ER negative, not much neratinib. Still, everybody's getting TDM1, a lot more, but not all neratinib. Any comments, Joyce? One of the other things that was really interesting about this is there were a number. We also asked people to say, what would you tell a patient in terms of the risk of recurrence with and without therapy? And there were a number of people who said, I would tell this patient they would have benefit by neratinib, but then when we said, would you recommend it, they would say no, which is, I'm sure, related to the perceived toxicity. Any thoughts?
Yeah, I think the science is so compelling with the combination of endocrine therapy plus neratinib. It just makes so much sense. That's the two main drivers, the HER family and ER. And if you just block ER, you're going to absolutely have overexpression of the HER family. If you block them both, you get much better kill preclinically. And we have good data with late-line neratinib that it is non-cross resistant with TDM1 and with pertuzumab. So it's a non-cross resistant agent, as the TKIs really are. We saw that with tucatinib as well. So I just think if patients have residual risk, we should offer them everything we possibly can, and so I think it's and now we just have to get the patients up to the number of pills they can tolerate per day and just keep them on it for 1 year, and then they stop and they get this continued benefit. So to me, it's a very, very important strategy for the high-risk patient.
So we're going to move on. We may come back. We're getting a lot of questions about HER2-positive disease. We might bring a couple of those back, but let's move into a triple negative disease. And again, Mayan has a great case. But first, let's take a look at some data, Aditya.
It's great. Good morning, everyone. So I'll review triple negative breast cancer. I'll start with neoadjuvant therapy, talk about adjuvant, and then talk about management of metastatic triple negative breast cancer. So in terms of neoadjuvant, the Keynote 522 has been a practice-changing study and pretty much has established chemo plus pembrolizumab as the preferred neoadjuvant regimen for a patient with triple negative breast cancer, carboplatin, paclitaxel, and then after that anthracycline with cyclophosphamide in combination with pembrolizumab. In terms of eligibility of Keynote 522, it was for patients with lymph node positive disease, or if you were lymph node negative, then T2 to T4. So a tumor size more than 2 centimeters or lymph node positive disease. The outcomes are very impressive. We saw not only improvement in event-free survival, but as presented at ESMO last year, there was improvement in overall survival as well with the use of neoadjuvant pembrolizumab and then adjuvant pembrolizumab to complete 1 year of immunotherapy. So this has been practice-changing and is the preferred regimen for a patient with triple negative breast cancer. The other thing to consider in this setting is a patient who has germline BRCA mutation, both triple-negative breast cancer, patient who has residual disease despite neoadjuvant therapy, which could include immunotherapy as well, or for a patient with hormone receptor positive breast cancer who has residual disease, as well as the CPS EG score of more than 3. In this setting, patients were randomized to receive olaparib, 300 milligrams twice a day for 1 year, or placebo. And again, there was improvement both in event-free survival as well as overall survival. So this has been practice changing for a patient who has residual disease despite neoadjuvant therapy. We would consider olaparib if a patient has germline BRCA mutation. If a patient had received neoadjuvant immunotherapy, then the consensus is in the adjuvant setting, you can do immunotherapy in combination with the PARP inhibitor. In terms of subsets, all the subsets derive benefit. There was a trend in terms of patients who received prior platinum. The confidence interval crossed 1, but this is subset analysis. In clinical practice, even if a patient has received prior platinum in the neoadjuvant setting, we tend to use olaparib in the adjuvant setting. In terms of safety, no major safety signal. There was a concern about MDS, AML in the adjuvant setting, but that was not seen. The updated long-term safety data presented at SABCS last year showed that there was no increased risk of MDS, AML with the use of olaparib. How about metastatic setting? In the metastatic setting, olaparib is also approved for patients with germline BRCA mutation. It's also shown activity in patients who have germline as well as somatic PALB2 mutations. PALB2 is related to BRCA, and actually pretty impressive result, response rate of 75% seen with olaparib in this setting. In patients with somatic BRCA mutations in the metastatic setting, responses to olaparib have also been seen, overall response rate of 37%. So it is a drug that could be considered not just for germline BRCA mutation, but also somatic BRCA mutation as well as PALB2 mutations in the metastatic setting. Now, switching gears and talking about metastatic triple-negative breast cancer, first-line setting, Keynote 355 was a practice-changing study. It was for patients with metastatic TNBC who had PD-L1 positive tumor. This was determined by CPS, or the combined prognostic score. A score of 10 or higher was considered PD-L1 positive. And in this PD-L1 positive group, so CPS score of 10 or higher, there was improvement in progression-free survival as well as overall survival with the addition of pembrolizumab. So that's practice-changing. That's a regimen that's FDA approved for PD-L1 positive metastatic TNBC. In terms of subgroups, the team looked at different cutoffs. For cutoff of 1 to 10, you didn't see benefit with pembrolizumab. 10 or higher, you saw benefit with pembrolizumab. 20 or higher, you saw benefit with pembrolizumab as well. So that's why our definition of PD-L1 positivity at this time is CPS score of 10 or higher. In terms of safety, AEs related to immunotherapy, similar to what's seen in other disease settings as well. It can result in immunotherapy-related AEs, which can include hypothyroidism, hyperthyroidism, pneumonitis, colitis, and then you have chemotherapy side effects as well, including myelosuppression and alopecia. So that was first-line setting. In the second-line plus setting, that's where ADCs come in. Sacituzumab govitecan was the first ADC approved for metastatic TNBC. It's a drug that targets TROP2 and has SN38 as the payload. In the ASCENT study, was compared head-to-head against chemotherapy. And there was improvement in progression-free survival, close to tripling of progression-free survival seen with sacituzumab govitecan, and improvement in overall survival as well seen with sacituzumab govitecan. So practice changing, and that's the recommended second-line regimen, including patients with PD-L1 positive metastatic TNBC. After they've had disease progression on immunotherapy in the second-line setting, SG is a drug to consider. In terms of safeties, AEs related to SN38, so myelosuppression, diarrhea, nausea, as well as alopecia. Neutropenia is a common side effect seen with this medication. Generally recommend secondary prophylaxis, although for some patients, you could even consider primary prophylaxis with GCSF. The second ADC in this setting is TDXT. This was evaluated in Destiny Breast 04, which was largely a trial for hormone receptor positive breast cancer, but also included 58 patients who had triple negative breast cancer. And in triple negative breast cancer, you could see a response rate of 50% with TDXT as opposed to 16% with standard chemo. And if we look at progression-free survival, clear benefit with TDXT, median PFS of 8.5 months versus about 3 months with standard chemotherapy, hazard ratio 0.46. Small numbers, there were only 58 patients, but despite small numbers, you could see clear separation in favor of TDXT. So that's another drug to consider for HER2-low metastatic TNBC. In terms of overall survival, again, improvement in overall survival seen with TDXT. In terms of other drugs in this space, datopotamab deruxtecan is a TROP2-directed ADC that's being evaluated in this space, both as a single agent as well as in combination with immunotherapy. The Begonia study was a phase 1b/2 study combining dato-DXd with durva in the first-line setting, so very similar to Keynote 355. And you saw a very impressive response rate of close to 80% with the combination of dato-DXd plus durva, and that was seen both in patients with PD-L1 positive metastatic TNBC as well as PD-L1 negative metastatic TNBC. So very impressive response rate, and this has now led to phase 3 clinical trials. The TROPION-Breast02 is looking at dato-DXd versus standard chemotherapy for patients who are not eligible for immunotherapy. So that's both patients with PD-L1 negative metastatic TNBC as well as patients who got immunotherapy in the neoadjuvant adjuvant setting and are not candidates for subsequent immunotherapy use in the metastatic setting. So this trial is ongoing. We'll likely see results sometime this year. TROPION-Breast05 is again in metastatic TNBC first line, but here it's being combined with immunotherapy. So dato-DXd plus durva versus investigated choice of chemotherapy plus pembro. And to look at contribution of components, it has a third arm, which is dato-DXd alone.
So thank you. We're going to move on. And again, mine has a great case of triple negative. But before we get to that, real quick, Ginger, we were talking even last night about this issue of HER2 ultra low, which was demonstrated to be of benefit in ER-positive patients, but I don't think they studied triple negative. You know, again, we go around and ask people what they do. I've been asking people, well, what about ultra low hormone receptor negative patients? Would you use TDXD?
So we do not have data for that. It would be a leap of faith taking the data from DB06 and applying it to DB04, which, you know, I say that we have other options in the triple negative space independent of the HER2 status. So sacituzumab govitecan works equally well, whether they're HER2 low, ultra low, 0. We now have dato-DXd. But we have SG. And, you know, so I have not yet gone in that direction. And as we talked about last night, finding a level of HER2 staining in old biopsies, having a conversation with your pathologist, what you're asking them to identify, and also, if possible, rebiopsying and getting a fresh sample to really make sure that you know what the patient's HER2 status is to be able to offer them the drug you think would be best.
In general, just as a follow-up, in general, in your patients who are HER2 low and hormone receptor negative, what comes first, sacituzumab or TDXD, and does that vary based on the situation?
So hormone receptor positive.
No, negative, triple negative.
Oh, triple negative.
HER2 low.
HER2 low. Second line, you know, it just kind of depends on what they've previously been treated with, what's the pace of the progression of their disease. Rapidly progressing, I do like to reach for the DXD because the response rates there are fast and deep. But if the patient is not in a situation where I feel there's a strong reason to give them one or the other, I talk to them about the different side effect profiles, the requirement for the added imaging in a constant fashion for the ILD on the TDXD, and the other differences, and try to help them make a choice.
So Hal, we did an incredible webinar, I think it was last week actually, with Mark Robeson from Memorial and Kevin Hughes on a topic that I thought was going to be pretty straightforward, which is BRCA testing. And then we started looking into it, and I came up with this scenario here of a 70-year-old woman without a family history. Do you do BRCA testing on her? Because what we found when we looked into it was that NCCN, in terms of people without family histories, not Ashkenazi, et cetera, just based on age, would you do BRCA testing? So NCCN says under 50. ASCO, that Mark had led the recent guidelines on, said 65, and the American Society of Breast Surgeons says everybody. So just keeping that in mind, and then we did a survey of the surgeons themselves, and all over the place in terms of what age they were using, but we'll get to that in a second, because I want you to hear Mayan's case that I think is relevant. So Mayan, what about this 46-year-old woman?
Okay, so that's an interesting case because it's a 46-year-old who presents with a breast mass. She gets a biopsy and it comes back as a ER weakly positive. They have like a percentage, so it looks like a machine, not a doctor read it. PR negative, HER2 negative. So we do the workup. I actually sent for mammoprint just to see if, because it's about the larger side and there was a concern about axillary lymph nodes, so I want to see, if she go for new adjuvant. She goes to a tertiary center and she decides to do bilateral mastectomy before I even get the results, and she gets a procedure. Unfortunately, when the test came back, it showed that she had basal type, and the mammoprint doesn't repeat the ERPR, so they assume. But then, when you see basal type, you get concerned about triple negative. So I called the oncologist at the tertiary center and tell me, I think she needs adjuvant therapy because she's young and she's high risk. And he goes, so they repeat the test and she's triple negative.
They did Oncotype too, right?
Yes, and they did Oncotype, and she was also triple negative. She was ERPR negative, HER2 negative. So she has the institution test was negative, Oncotype negative, and the mammoprint basal type, which you see with mostly, with triple negative. So now she missed the opportunity to get immunotherapy as a new adjuvant. I did treat her with AC and added carbo also to the T. And we did the genetic testing. She has BRCA1 mutation. So after she finished chemo, I saw olaparib. But now, so the two questions that I have, because she's a young lady, she want to do everything, to make sure she's getting married again. And now they want to take, take out her ovaries and uterus, which I recommended, yes, please do that. But the question is, any way, immunotherapy can have a role, that's number one. Number two, for surveillance, should I do ctDNA? And the third question, the tertiary center is now recommending she starts on hormonal therapy, even though their test was negative, just because the initial biopsy showed a 1.1% maybe ER positive. And I hate to put her through more, toxicity. So it's just she was in a rush, did the surgery, didn't wait, and I think that really messed up the whole.
Real world.
Mm-hmm. Right.
Real world.
Yeah.
Al?
Just how big was the tumor at baseline?
I think it was a T2.
T2.
Yeah.
So what to do about these ER low positive cancers? They usually have expression read out as 1 to 10%. And it's an interesting group of tumors because about half of them have molecular signatures that look like luminal type cancers, such that they really might have some sensitivity to endocrine therapy. And about half, as in this case, have a signature that looks pretty consistent with a basal-like or a triple negative breast cancer. So at this point, having had surgery, I would agree that she should get our sort of A-game chemo regimen, which at the moment is AC followed by taxane carboplatin combination, or if you want to flip the sequence around, that would be fine. I have a pretty low threshold for giving endocrine therapy to these ER low cancers, but in this case, it sounds like most of the evidence says it's pretty estrogen receptor negative, and so I would probably not bother. I think in the next couple of years, we're going to see mature data from two important studies that were presented last year. One, Keynote 756, which is essentially the Keynote regimen we know in breast cancer, without the carboplatin, but the same structure otherwise with looking at pembrolizumab. And what was interesting is that the pathologic complete response rates in these very low ER-positive tumors look very similar to triple-negative breast cancer. There was a related study looking at nivolumab with the exact same findings. So the guess is that for these very low ER cancers in the next couple years, we will actually shift to this paradigm of preoperative immunotherapy plus chemotherapy, and that'll be important for a patient such as you describe. But at the moment, there are no data that adding a checkpoint inhibitor after surgery would be clinically active. We do not routinely do that. It means it's really important, especially if you're on the bubble about cases. It's a 2 centimeter. Well, on the MRI, it was 1.6 centimeters. Is it still worth doing preoperative therapy? And those are really tough cases because inevitably, if you operate on those patients, a couple of them will have some residual disease in the nodes, and you sort of worry that you've missed a chance to give the regimen. At the same time, it's a tough regimen. I've hospitalized more patients in the past 2 years on Keynote 522 than in years previous to that when we were giving like ACT as our standard regimen. It's just a lot harder. There's more myelosuppression, colitis, pneumonitis, adrenal insufficiency, thyroid disease, obviously. And so, it's a big lift for the patient to get that if they don't need it. So right around 2 centimeters is the break point. And I think the Keynote 522 study, as Aditya presented, really does emphasize the importance of preoperative therapy, because there's 2 things we didn't expect in Keynote 522 that were really true. The first is that the historic assumption was that adjuvant therapy was always the same as neoadjuvant therapy, right? That's why we did all these neoadjuvant trials, because the thinking was you were giving the exact same therapy as adjuvant. And in triple negative, that's no longer true. We have studies that if you give adjuvant checkpoint inhibitors, they do not work, but in the neoadjuvant setting, they do work. So the paradigm changes there. The other interesting thing is that the endpoint of PCR was not the best discriminant of long-term benefit. It's the patients who had partial responses but had residual disease who actually get the most benefit from pembrolizumab. Again, an unexpected finding, and again, a reason why PCR is not the important endpoint here. It's really event-free survival.
Really interesting about the tolerability. I hadn't heard that before about 522. Ginger, you had a thought?
Well, I just wanted to say in this patient, you actually have a little bit of an out that you don't really need to make a decision about endocrine therapy because she's 46 with a BRCA mutation. You want those ovaries and tubes out. And surgical ablation of the ovaries is the original treatment for hormone receptor positive breast cancer. So you're going to give her endocrine therapy for a totally different reason. I would not add a pill on top of that because we know that's quite good treatment for her.
Yeah, I think I need your opinion because I'm fighting a tertiary center, so now at least I have an opinion.
You have a little ammunition there. Joyce, you had a comment. And also, Joyce, can you comment on your experience with olaparib in the adjuvant setting in terms of tolerability, dose reduction, et cetera?
Yeah, I want to just mention the ABRAVE trial because this was a trial from Italy where patients with triple-negative breast cancer had either preoperative chemotherapy or adjuvant chemotherapy. So they finished their chemotherapy. If they had pre-op, they had to have residual disease, but there was a cohort, 20% of them or so, who had done adjuvant therapy. And then they were randomized to a year of single-agent avelumab, which is an anti-PD-L1 antibody, versus not. And there's a survival advantage in favor of the checkpoint inhibitor. There's the Alexandra trial, which was the Impassion 030, which was atezolizumab in the adjuvant setting with chemoptherapy in the triple-negative, totally negative trial with atezo, and this was with avelumab. So there may be some differences between these checkpoint inhibitors. So I actually would, in a high-risk patient, and does she have nodes?
She had MI, like
I usually do put the checkpoint inhibitor in there if the patient otherwise would have been a candidate for the 522, which she would have been. I usually do add it. I use the ABRAVE. And then we're waiting for the SWOG 1418, which is which is the single-agent pembrolizumab in patients with TNBC in the adjuvant setting after they finished their chemotherapy, residual disease, preoperative chemo, residual disease, pembro versus not. So we're waiting on those results. So we'll see those, and those will be, probably more. Well, that will really help this question as well. But the ABRAVE data were interesting. It did not have a stat-sig IDFS improvement, but there was a stat-sig survival improvement. So I usually find olaparib well tolerated in general. There have been a few patients that have gotten anemia, and I've had to reduce the dose. It was enough, but there's a tachyphylaxis for the nausea. It doesn't happen to everybody, but some people will have some low-grade nausea. I mean, it's the kind of thing that's easily managed with a compazine PRN or something, but it goes away after a couple of months. But I have found good tolerability, but a minority need a reduction because of anemia.
So we'll hear more about that when we do on our ovarian cancer program. I had this question about PALB2 in the metastatic setting that we saw some data on, but just kind of curious, Joyce, if you could, would you use olaparib adjuvantly with a PALB2 patient?
Definitely, and I find that that's a growing consensus. Actually, I think that's very important. It's a mutation that PALB2 is very, very similar. Works very closely with BRCA2, so you can think of them as almost the same. So I think it's important.
So we're going to move on now. The second part of this is going to focus on ER-positive disease. And last night we talked about metastatic disease, but I just wanted to bring this back up because it was so important. We brought it up, and I know not everybody who's here or online was online last night, but this was described as potentially practice-changing. So just a word about the SERENA-6 study. Aditya, can you talk a little bit about what the SERENA-6 trial was looking at? Last night I was saying it kind of reminds me of treating prostate cancer in the M0 stage based on a molecular marker, in this case ESR1. And now we have a press release, hopefully, I guess maybe we'll see this at ASCO, that this study is positive in patients who are clinically stable but now have developed an ESR1 mutation, treated with a as yet unapproved oral SERD camizestrant. We already have elacestrant. Imlunestrant has some really good data from EMBER-3. Probably that might get approved. Aditya, can you talk about what they looked at, what the press release showed, and what you think is going to happen over the next couple of years?
Yeah. This was kind of a hybrid first-line, second-line study. This is for patients who are on first-line CDK4/6 inhibitor, palbora/bema, with endocrine therapy, and they're monitored for ESR1 mutations. So in the first-line setting, if there's a rise in ESR1 or detectable ESR1, patients switch to continue the same first-line therapy or switch the endocrine therapy to camizestrant and continue the same CDK4/6 inhibitor. They screened about 3,000 patients and about 300 were randomized to the switch versus continuing the same endocrine therapy. And as per the press release, this was a positive study, improvement in PFS, which we had expected based on what was seen previously with the PARA study, because if you switch to camizestrant, it's likely that you'll see an improvement in PFS. I think the more important question would be PFS2, whether the early switch has an impact, as well as overall survival, whether the early switch versus routine switch would ultimately impact overall survival. But it's very exciting data and potentially brings a third oral SERD into the mix.
So we'll see. Again, you can check out, if you weren't here last night, the extensive discussion we had about that. But just wanted to alert you to that because this really, hopefully, will come up soon, and we'll have a new strategy to employ. So we are going to move into hormone receptor positive disease. Ginger is going to talk about personalizing adjuvant therapy, and Hal's going to get into the issue of CDK inhibitors in the adjuvant setting. I got a bunch of great triple negative and HER2 positive cases we might bring up that have come in online. And mine has another case too, but let's keep going with our schedule first. So Ginger?
Taking it away. Thank you so much, Neil. So those are my disclosures. I was given a couple of different topics here to cover in 10 minutes, so we're going to go through this quickly. Hold on. So how do we make decisions in adjuvant therapy? Who should we be giving chemo to in the hormone positive, HER2 negative space? And how do we make choices about endocrine therapy and for what duration? We have a number of different prognostic genomic assays. They're listed there. For today, we're going to focus on the 21 gene assay and then the 2 gene ratio for how we can use that in the extended therapy setting. So the TAILOR-RX data have been around for a long time, and this is my schema breakout of what it showed us. In the postmenopausal patients, it was a fairly straightforward yes-no decision focused around 25 versus 26. In our younger patients, there was a bit of a spectrum. I interpret this data this way. I think it's straightforward that if they're not going to get benefit, we don't give it. I think it's very straightforward that if they're going to get a great benefit, we give it. Fairly straightforward, I list, because I personally don't recommend it for the 16 to 20 group in my young women, but I have heard other oncologists say different. And in the postmenopausal, the fairly straightforward is just recognizing that we do have some very elderly patients with a lot of comorbidities where maybe you would still need to think about it. For me, the shared decision-making comes in at the 21 to 25. It's a research opportunity. TAILOR-RX, most of these patients had tamoxifen, and so we have a clinical trial ongoing right now, the offset study that's going to help answer that question even in the node negative. In node positive disease, we had the responder trial and the MINDAC trial, both using genomic assays to try and help refine who needs chemotherapy. And focusing on the responder, here's the baseline characteristics. I just want to bring to your attention that while there were patients in the premenopausal range, really only a few, 141, who were under 40 years of age in that group. And there was a pre-planned decision to break out the recurrence score by 13 to 0 and 14 to 25. Summarizing it the same way I did for TAILOR-RX, in the postmenopausal patients, it remained equally straightforward, a dichotomization around 25 versus 26 who did and did not benefit. In our premenopausal patients, all of them had a benefit. From the 0 to 13, it was about 4%, 14 to 25, 6%. And so I like to think of it as if you just remember the number 5%, you're in the right territory. And interestingly, most of the patients in this study did receive an anthracycline-based regimen, about 54%, 46% improvement in invasive disease-free survival, and it was across all premenopausal subgroups. The overall 5-year survival was 1.3%, and there was an equal benefit independent of the number of lymph nodes involved, which I thought was quite interesting. And again, I emphasize the 5% difference because from the MINDAC study, we see the almost identical results. Women under 50, 5% gain for chemotherapy if they were clinically high risk, but genomically low risk, node positive. So what chemo should we give them, and can we make better decisions than we have in the past? These are the overview data that shows the benefit for anthracyclines, but we know that the hazard ratios were driven mostly by if patients were under 54, ER negative, node positive, high grade, or HER2 negative. But we'd like to do better than just using these big buckets. So we saw data at San Antonio about the impact of anthracyclines in genomically high-risk node negative breast cancer from Dr. Chen and group. These are the patient characteristics, and the thing that I'll draw your attention to on this slide is since the physicians could vote on what type of treatment they gave the patient, you can see that with the increasing recurrence score, there was a more frequent choice to the anthracycline-containing regimen. When we look at the distant recurrence-free interval at 5 years, if the recurrence score was over 31, we see it favoring the anthracycline-containing regimens. Similarly, if we look at it based on premenopausal versus postmenopausal, in those whose recurrence score was over 31, higher benefit in those who were premenopausal. So I would say this is very practice-informing. As the recurrence score goes up, the hazard ratio improves. And what you see here is if you set the hazard ratio of 1 to the benefit of TC times 4, the blue line, which is the anthracycline-containing regimens, shows a markedly improving hazard ratio, where all the other choices, AC or even some CMF that snuck in there, did not have as much benefit. So this is, in my mind, concordant with what we saw from the overview data of the benefit of the anthracyclines, but also Dr. O'Shaughnessy here presented similar data using the 70-gene assay and the high 2 luminal type tumors receiving significant benefit of anthracycline at ASCO last year. So I would now definitely consider an anthracycline for someone whose tumor is over 2 centimeters lymph node negative, but with an oncotype over 31, of course, weighing the risks and benefits of anthracyclines in that patient. Skipping now to the second topic of for whom should we extend the endocrine therapy and how can we decide this? There have been a large number of studies looking at this, and if you remember the number about 4 to 5%, that is the absolute benefit that was seen across most of these trials. Many of them had tamoxifen first, followed by crossover to either extended tamoxifen or an AI. Some of them had AI followed by AI, but none of them have shown an overall survival benefit. And when you look at the meta-analysis of using prolonged duration of AI, what you can see is that the majority of the benefit really arose in those who had 4 or more lymph nodes, a smaller benefit in the node negative and intermediate in the 1 to 3. Benefit was most pronounced in those patients who had 5 years of tamoxifen initially as opposed to adjuvant AI. And in fact, there is data to say that if you were going to have 5 years of AI and extend the therapy, 2 years showed a difference, whereas full 5 years did not seem to add additional benefit. We know that recurrences persist in our ER-positive patients, and they are driven by nodal status. But most patients aren't benefiting from this continuation of the treatment. So do we have any better ways that we could make these choices? There is a validation, there is a genomic assay that looks at the ratio of 2 genes, and it's been validated in several studies. You see them listed here, where if somebody comes back with a high-risk score, it appears that they do derive more benefit from the extension of the therapy, particularly in node-positive cases, as you might expect. And there's also some additional studies that break out where the significance of these values lie across all of these different trials, some of which were AI to AI, some of which were TAM to AI and various algorithms. So this assay has now been adopted into the NCCN guidelines with the caveat that if somebody is node negative or with 1 to 3 positive nodes and has had 5 years of endocrine therapy, no recurrence, you could use this test to decide who to continue on. If they're node positive with 4 or more, really there's no reason to use a test. We know how much they're going to benefit in those patients. It should be a discussion. Personally, I would say, the data is in the eye of the beholder. I have had some patients who asked for this and I have gotten it. And it came back, yes, that they would benefit, but it was really going to be about a 1.8% benefit for 5 years of extended therapy. And I think that's very much a conversation for that much added toxicity. So what should we do for our premenopausal women in terms of optimizing their endocrine therapy? Again, going back to the overview data, we have seen many trials looking at the use of ovarian suppression with the injectable drugs and overlapping that with chemo or tamoxifen type regimens. None of these really had AIs. And over the overarching data, we see that if a patient did not receive chemotherapy or persisted in being premenopausal after chemotherapy, ovarian ablation added benefit for mortality. It did not increase non-cancer deaths, did improve all-cause mortality, which in this young population is breast cancer death. And so even in our youngest of patients, we get a lot of benefit out of this. And as you can see here on this forest plot, it's those patients who were really very premenopausal at diagnosis as opposed to possibly more perimenopausal who had the bigger difference, although it benefited anyone who was remaining premenopausal. So this led to the SOFT clinical trial, which was run in companionship with the TEXT trial. SOFT was the one that had tamoxifen monotherapy compared to ovarian suppression with either tamoxifen or an AI. TEXT, everybody got the OFS. And when we look at the 12-year follow-up of the SOFT population, we do see absolute benefit for the incorporation of ovarian function suppression, slightly favoring the use of the aromatase inhibitor with that as well for both DFS and OS. When you look at those who received chemotherapy, so the somewhat higher risk population, they also derived significant benefit. And I really love this article by Dr. Pagani in JCO in 2023. She breaks out the subgroups who get the differences seen. And for our patients who were over 40, did not need chemotherapy by whatever criteria was used, there wasn't a big difference between tamoxifen and the use of OFS. So in those patients, I'm telling them that tamoxifen is sufficient still, whereas in our younger node positive, needed chemotherapy patients, I'm offering them the combination. So we also have to keep in mind in our younger patients the issues of fertility when we are giving them chemotherapy. And I always start with counseling my patients that if she has never been pregnant, we don't really know what her fertility status is. And Mother Nature starts to take that away from women at the age of 35. So getting them into the oncofertility team to figure out what their baseline fertility looks like is very important. And then our modern chemotherapy regimens are not as bad as when we were given oral CMF type regimens, but still there is a loss of ovarian function. And so sending them to have genetic material banked if they want that is both acceptable and really strongly recommended, even if they are going to need neoadjuvant treatment. We have time to do this. And there should be strong consideration given to ovarian protection. I'll cover that in a second. We know that having a pregnancy post-treatment does not increase breast cancer recurrence from both many retrospective series and now the positive trial in our hormone receptor positive patients who choose to interrupt their therapy between 18 and 36 months and sequence a pregnancy in between. However, it's incredibly important that we get them back on their treatment afterwards, or they are not going to continue to reduce their risk. Now, let's be clear, it doesn't increase their risk. It does not decrease their risk. Recurrences will happen in patients who have children if they are high enough risk. So there has to be a conversation about that as a person is considering to go forward. And of course, never forget that now is a really bad time for this person to become pregnant, so get them on good contraception. Ovarian function suppression alone is not adequate contraception. We now have several studies that have looked at the use of ovarian function suppression to preserve fertility in our patients with either TNBC or ER positive. And the bottom line is it does work. We see a higher rate of successful pregnancies achieved afterwards, as well as less permanent amenorrhea derived from the chemotherapy. So the ASCO guidelines say this is something that we should be offering all of our young patients to avoid chemotherapy-induced ovarian insufficiency. And yeah, almost 10 minutes.
Awesome. Great job. So in a second, I want Joyce to talk a little bit about the issue that you were commenting on here of anthracyclines in ER-positive disease, also, based on recurrent 17-gene assay. Mayan, I'm going to ask you in a second how you have been approaching choice of chemotherapy, particularly in your node-negative high-risk patients. But first, Ginger, just to follow up on the last thing you talked about, which was the positive study of interrupting adjuvant endocrine therapy to allow a premenopausal woman to attempt to have a child. Last night, Joyce presented a patient who had metastatic disease, and we went back and looked at the history, had the positive strategy. So she was node negative. She stopped, I think it was adjuvant tamoxifen, Joyce, and also
and OFS.
And OFS, and then nursed for a year, I think, and then developed metastatic disease. So it's a tragic situation of, when you look back and go, well, maybe this might have been avoided, terrible. That's what the risk you take with positive. We were talking about it last night before the conference, Ginger, you all brought up the issue of nursing and how you counsel patients about it, your thoughts. Could you kind of echo that a little bit, Ginger?
Sure. So in that case, again, very sad that she has gone on to develop metastatic disease. I would not relate that event to the fact that she chose to interrupt her therapy and have a child, because both the retrospective data, particularly from our colleagues in Europe, and now also the positive trial would suggest that that was not the cause. However, and this is a very good representative case, and I have some in my own practice where I find it incredibly important to have this conversation with our patients who still have breast for the opportunity of nursing, that if they're going to sequence off their treatment, particularly if they're within that 18 to 36 window, that we want to allow them some opportunity to nurse, but not for as long as they might like. In Colorado, women will nurse for years, and that's great if you choose to do it, but they got to get back on their treatment. And so depending on how risky their original breast cancer diagnosis was, T1A versus stage 3, and also how long it takes them to get pregnant, because in the positive trial there was a 2-year window where this was considered the time frame in which to achieve becoming pregnant. So if they get pregnant right away, they had banked material, then perhaps letting them nurse for, I start off with saying, how about maybe 3-6 months, but then I want you back and I want you getting back on your treatment. And I do not think it's at all safe for them to continue off of their treatment for the purpose of continuing to nurse, and that can be a very challenging conversation with some patients. So I have it before they go off their treatment.
So we could talk about this and a lot of other issues a long time, but we were just kind of alerting you to some things to give some thought to. Mine, any thoughts or any questions for Joyce? You know, I was kind of this anthracycline thing kind of, crept up on me. I'm like, whoa, where did that come from? How have you been? What kind of chemo are you using?
Yeah, actually, I go with her findings. So I do look at the oncotype or any of those tests. And if they really have like a higher, if they're in the high risk, but they're in the high risk, I do offer the anthracycline. But if they're in the lower part of the high risk, I do discuss both options and see how the patient feels. I don't push as hard for anthracycline. Especially in the younger women. Now, the older women, I usually just recommend TC, even if they're high risk, just because of the morbidity. Unless they're in really good shape and their life expectancy could be like 10, 15 years, I might add anthracycline. They're really high risk. So I do kind of look at what the level of high risk thickness, let's put it this way.
Joyce, any thoughts? What do you do?
I have, so when I know I'm going to recommend chemotherapy, somebody's high enough risk, but I'm on that fence between TC and ACT. I have come to be ordering the blueprint now and get the intrinsic subtyping because of the data I presented at ASCO. And this is from the FLEX trial, which is a very large prospective registry, but the chemotherapy is definitely not randomized. So they're not randomized to TC versus ACT, but we found now with 3-year median follow-up, the 3-year IDFS was superior if they had the blueprint. It's actually MammaPrint high 2. MammaPrint high 2, and the basal-like patients in the blueprint can also benefit, but it was the high 2 patients, and this is luminal B, high 2 patients. High 1 patients did not get any differential improvement in IDFS with anthracycline versus TC. And then we saw at San Antonio, we saw a similar story, again, not randomized from Taylor X, those who got ACT versus TC, and if they were 31 and above, they got benefit from the ACT, and if they were 30 and below, they did not get benefit from ACT, just so TC, again, not randomized. So, but these data are, we have our ABC trial, our prospective ABC trial of ACT versus 6 TC, and because of the 21 gene recurrence score and the 70 gene signature with the high 2, we're going to do, we're going to apply for sure the 70 gene signature and the high 2, look at that question. Hopefully we'll look at other signatures as well. I think that would be reasonable to do.
We're going to go on in a second and talk about the use of adjuvant CDK. Hal's going to review that. But Hal, I'm just curious how you're thinking through anthracyclines. Also the issue of, the age-old issue of, oncotype versus other assays, including MammaPrint. We have this question here in the postmenopausal patient with the node-positive disease. How many nodes positive are you comfortable with holding therapy for? Which recurrence score? Where are you today at Dana-Farber in terms of these assays and what you do about it?
Yeah, well, the first thing to say is that ER-positive breast cancer in the early stage is both the most prevalent and the most heterogeneous flavor of breast cancer. We treat all HER2 positives more or less the same reflecting stage, and the same for triple negative. But within ER-positive, as we've already discussed several contexts now, we have ER low, we have the interplay between menopausal status and outcome, and we have these molecular tests which seem to stratify patients into those that need chemotherapy and do not. And I think what's exciting about the study that Joyce led and the data that Ginger just presented is we're really getting beyond this idea of using the molecular assay for sort of a yes-no decision on chemo to refining the treatment more and more based on those kinds of results. And I thought that the message from the FLEX study that Joyce led and the update on the Taylor X were pretty compelling, that if you're in the higher range of risk, it's just a risk, it's the biology is less good here, then anthracyclines add something meaningful. So the cut point is MammaPrint high 2 or Oncotype DX greater than 30. And by contrast, if you're not, then you can spare the patient the anthracyclines, and that's quite constructive. It lowers the risk of heart damage, which is real but fortunately rare. There was a brilliant editorial on this in the JCO about a month ago by myself, and so you can read that if you like. I think that it's a really nice use of these assays to not just say yes or no on the chemo, but to further refine. The other question that comes up then, and you alluded to, is this issue of stage. So we have really good data for in the RxPonder study of postmenopausal women, with 3 nodes. What if they had 4 nodes? What if they had 5 nodes? I don't think anybody believes the biology is fundamentally different there. At some point, if you have stage 3 breast cancer, your hand is sort of forced to think about chemotherapy. The other context this comes up in not infrequently is patients who have lobular breast cancers. There's a big lobular tumor, multiple positive nodes. We think they are rather insensitive to chemo. The oncotype score, which is our preferred assay, comes in low. But, if they have 5 positive nodes, do they really not benefit at all from chemo? But you can use the data to frame the conversation with patients, and usually patients are pretty open to thinking it through and make good decisions for themselves, has been my experience.
So we're going to move on in a second, talk about CDK and the adjuvant thing. But I got to say, it's been great working with you all the last 2 days. It's really awesome. Really look forward to it. Has not disappointed, exceeded my expectations. It's really been fun to work with you. Hal, before you get into the data, I want you all to hear a case. Mayan, you have this 62-year-old lady. And Aditi, I'd like you to listen to this case and tell me what you think you do.
Okay, a 62-year-old lady presented with the right breast nodule, and she did have a lump, had a biopsy. It was ER-PR positive, HER2 negative. It was a grade 2. The pre-op staging was T1 and 0, T1B and 0. I did order mammoprint pre-op just to see, and it was actually luminal B, high risk. So she did go for biopsy, for surgery, lumpectomy and sentinel lymph node biopsy, and it was T1B, but unfortunately she had one lymph node that had the positive, so now she's an N1. So I did offer her, because she was a high-risk luminal B, I offered her anthracycline. So I did give her AC followed by, actually did those dents, and then she had radiation, started an AI after that. Now I'm trying, this is a lady who's very active and she want to enjoy life. She went through chemo, but she had a hard time with it. She has some vanity issues too. And so the question is, how strong should I be in offering her a CKD4/6 inhibitor?
I would say also which one.
And which one, right? The least I will be, I make sure that she can be compliant with and not decide, okay, I'm done, I don't want to take it anymore.
Aditi, yeah, it's so great. We've been having people present cases ever since the pandemic on video, and it's so different when you hear a real patient being presented, because it's never like when you go, you just put up a case. There's always something you have to think about. You can get the flavor for. Aditi, I think you're hearing a little bit that here. Any thoughts?
Yeah, for this patient, so the patient has T1B/N1 disease. In terms of CDK4/6, she would have qualified for the NATALEE study, so one could consider ribociclib because that included anyone who has lymph node positive disease. She would not have qualified for monarchy because if it's lymph node positive, then you need one additional risk factor, which could be grade 3 or tumor size more than 5, which she didn't have. So if I were to consider CDK4/6 inhibitor, it would be ribociclib. With luminal B, given that you can have endocrine therapy resistance to single agent, I would lean towards a CDK4/6 inhibitor. You start with CDK4/6 inhibitor. If she has difficulty tolerating, you can always stop. In the NATALEE study, up to I think 18 months, you could start CDK4/6. If the concern is after chemo, she's not recovered, I would start endocrine therapy, but then just put it in my notes. So when she comes back for follow-up in 3 months, 6 months, at that time, I can introduce the CDK4/6 inhibitor. So
I can wait.
That can help.
Yeah, I can wait. I don't have to start it right, because that's the thing, her counts are still not there yet, and that was a concern too.
Absolutely, and as per the clinical trial, up to 18 months, you could start the CDK4/6 inhibitor. So I might just do endocrine therapy, give her some time to recover, and then later on add the ribociclib.
Thank you.
Would you prefer to give her a Bema if you could, Mayan?
A lot of diarrhea with them. I don't know. I feel like I had, easier route to have patients on the ribo instead of Abema. So,
Ginger, I'm curious whether, how you determine whether to use CDK and then which one, and, do you ever kind of lower the bar below where, the FDA indication the trials were in terms of offering CDK? Lower risk?
I have not. I will say that I have had patients whom I've started off on Abema, and if they weren't tolerating it, I have tried dose reduction, and if they still were not tolerating it, have flexed them over to ribo as an alternative. And I have a couple who have tolerated that better. You do have to then decide how long are you going to treat them for, because the abemaciclib was studied for 2 years, the ribo for 3 years. So without really any exact knowledge of how to do that. I sort of add, so whatever length of time they were on the abema, I contribute it to the 3 years that they would now be asked to be on the ribo for no better way of doing it. But in general, I follow the 2 algorithms. And if somebody qualified for monarchy, I will start them off on abema, particularly in my clinic, because a lot of my patients are going to want to come off of all of this therapy in just over 2 years to be able to go have a child. So having the shorter course of a CDK4/6 inhibitor sometimes works to the advantage in my clinic.
Would you do those escalation with the abema? We start with the lower dose and go higher. Find that
On the
abema?
You could.
Yeah.
Yeah, start at 100, and then if they tolerate it, go to 150.
Yeah.
Particularly in older people.
Okay.
And the younger folks, I just start them at the 150. But I do prophylax them for the diarrhea from the get-go.
What about people with cytopenias?
Well, I think Aditya's comment was perfect. We can wait a little, right? You don't have to get them on this medicine, 8 weeks after they just got their last dose of chemo, or, certainly we don't want to be overlapping it. This patient is potentially going to be getting radiotherapy with a positive lymph node, so we want to begin that afterwards. I'm a big fan of doing things in sequence. I find patients will be a little bit more accepting if you kind of ease it in, do this, then do that. Just, make sure they're coming back in for close follow-up and that they're not getting lost out there where all of a sudden it's a year and you haven't gotten them started.
So Hal, with this clinical discussion, let's take a look at the data. Maybe you can reflect back on some of these questions that have come up.
Sounds good. So obviously an exciting new therapeutic option for higher risk ER-positive early stage disease. So there have been multiple studies of adjuvant use of CDK4/6 inhibitors. The Pallas and Penelope study built around palbociclib, which did not show clinically important gains. And then the Monarch E trial and the Natalie study with abemaciclib and ribociclib, respectively. So these patients who went on to these trials all differed in little ways. The Pallas trial actually had the lowest risk group. If you look at the control arm, they had the best outcomes. The Monarch E study had the highest risk group of patients, and the Natalie trial and the Penelope study were somewhere in between. So again, it's a little tricky to compare head-to-head in all of these trials. I won't belabor Pallas. It was an addition of 2 years of palbo versus endocrine therapy alone, and did not show a difference in event-free survival or disease-free survival. The Penelope study is a really interesting trial. These patients had all had neoadjuvant chemotherapy and then were randomized to palbo for a year. The curves transiently separated but then came back together. So at the moment, no role for palbociclib in early stage disease. Monarch E was a large randomized clinical trial for patients, as Aditya just alluded to, high risk early stage breast cancer. So 4 more positive nodes, or N1 disease with either high grade or tumor size greater than 5 centimeter features. And then there was a small cohort that was added for a high Ki-67. That's generally concordant with grade 3, but probably also if you had a high genomic assay readout would incorporate those patients as well. 5,600 patients randomized to endocrine therapy alone or to abema plus endocrine therapy for 2 years. Nearly all these patients had chemotherapy. So one of the big questions we get asked is, can we use this instead of chemotherapy? And certainly on an individual case-by-case basis, we've talked about that. But particularly for the Monarch E study, almost all of these patients you would have looked at in clinic and said, gosh, you need chemotherapy. It's high grade, it's multiple positive nodes, or high genomic readout. So 2 years of abema in this setting. These are your disease-free survival curves at 5 years. I will just add these trials are still being actively monitored. So like every national meeting, there's an update on the latest progression-free or recurrence-free events with longer and longer follow-up. Here's Monarch E at 5 years showing roughly a 6 or 7% improvement or reduction in the risk of recurrence. And to date, no signal of survival benefit, and that's true for the Natalie trial as well. None of these studies have shown a survival benefit. I think that's important for 2 reasons. Obviously, it does at the one level ask the question of how much these drugs are really changing the natural history of the disease. The second point, and we'll come to this in a moment, it's actually really hard for patients to complete 2 or 3 years of these drugs. I don't think I've had a single patient who's completed a full course of therapy at full dose with either of these regimens. And so since they are inevitably going to be abbreviating or lowering the dose, their worry is they're compromising their survival. They are not. There's no survival signal for any of these drugs at this point. So they've looked across a whole number of clinical subsets, and in broad terms, the hazard ratio is very similar for tumors that are defined by the extent of nodal involvement or the stage or the choice of endocrine partner. If you look at inferred oncotype scores, and again, this is not an actual calculation, but they ran similar assays, again, the hazard ratio is roughly similar if the oncotype was 25 or less or 25 or more. So that's not going to allow you to discriminate which patients need treatment. They've looked at older folks versus younger folks. Older folks here being very young people in Miami at only 65 years of age, but again, no signal of significant difference in outcome that would favor one group or the other for choosing who gets the treatment with abemaciclib. So as was already alluded to, the major side effect here is diarrhea. It's quite an issue. You can modify the dose, you can prophylax with Imodium or other drugs. But, you know, for patients who are busy women, running around at work, taking care of families, going to the beach, nobody wants to have diarrhea. Like, that's the worst side effect you can imagine. They'd much rather have cytopenias because that's a clinical lab finding. Diarrhea is somewhere where you're at the mall and you suddenly have to find a bathroom. So this is a challenge for patients who are getting this medicine. I will also say that the time, 2 years is a long time, 3 years for a ribo. For any of these drugs, there is a grind you down factor that we see for all of these folks. Finally, you know, you start them on the drug and then you're putting on Imodium and then other antidiarrheals. The next thing you know, you're on 2 or 3 supportive care medicines to help them get this one medicine, and then becomes a discussion as to whether or not to continue. Small other footnotes, there is a risk of pneumonitis with this drug, so if you have patients who develop shortness of breath, they need to be evaluated for that. There's also a slightly greater risk of venous thromboembolism, probably a reason you don't want to give this with tamoxifen. Not that most of these patients should be getting tamoxifen as opposed to an AI anyway, but again, there is going to be a trade-off there. So dose modifications are early and often with this drug. These are data where they've analyzed very carefully the changes, and it just makes the point that a substantial fraction of patients, when you add it all up, it's at least half will have a dose reduction of treatment. Fortunately, the dose modifications do not seem to really affect outcome that much. I think patients are in good faith trying to take the most tolerable amount of drug that they can, which may account for some of that lack of impact on longer-term efficacy. Okay, so the competing study here is NATALY, and again, Aditya already alluded to this, of some important things to know about NATALY. The first is that the ribociclib dose was reduced to 400 milligrams a day because they recognized you couldn't get the 600 milligrams in so reliably. That's the dose in the metastatic setting. It's interesting that FDA went ahead and let them use that lower dose. It seemed to be effective, so that's an interesting finding, but it's not the standard approval dose in the metastatic setting. The second is that there is inclusion of a lower risk cohort of patients here. They had a substantial number of patients who had node-negative disease, provided that they had grade 2 with a high Ki-67 or oncotype score or other high-risk genomic assay, or were grade 3, or had nodal disease N1 or higher. So not surprisingly, the baseline risk here is somewhat lower than in the Monarch E trial. 3 years here. So this is just a table that there's a test on this at the lunchtime break, so you might want to write some of this down here. Neil has an extra slice of chocolate cake for whoever gets this correct. But this included a lot more potential patients in current U.S. practice. If you look at the disease-free survival now at the 3-year landmark, there's somewhat less follow-up reported to date. You see about a 5% reduction in the risk of recurrence from 83% up to 88% disease-free at 4 years in the current estimates. And I think it's been important to get the longer follow-up. You know, most of us have wanted to see that these curves separate and continue to move apart. If you look at the breakdown of events, there is difference in both the rate of local regional events and in distant metastatic disease, which comprise the collective disease-free survival benefit. If you look again across a variety of different subgroups, it's hard to see a unique group. people have pointed out that the hazard ratio here is a little less robust than in the Monarch E study. The Monarch E, it's about 0.65. In Natalie, it's about 0.75 on average, if you sort of squint your eyes here. Whether that speaks to the population that went on to the study or whether abema is a more potent drug here is hard to know. If you break it out by stage, stage 2 versus stage 3, relatively similar benefits. If you break it out by nodal status, node negative versus node positive, relatively similar benefits. Now, I would point out that the node negative here is not your 64-year-old with a 1.1 centimeter, low risk node negative cancer, where we know from studies like Taylor X that she has a 9-year recurrence-free survival of like 95%. This is a higher risk group that went on to these trials, and you just have to remember that. It's been very hard to actually see data for the T2N0s alone. They haven't shown a lot of that. This is just a further update again. No difference in overall survival so far, something to keep your eye on. So the side effects here for ribociclib include neutropenia, though there are very low rates of febrile neutropenia. There is a risk of QTc prolongation, so we're now getting all these EKGs on these patients. Actually, I think that's a relatively uncommon actual problem. It does carry a slight risk of pneumonitis. The biggest issue in my practice management has been that many patients, about 15%, will have LFT abnormalities, and these can often persist for weeks, if not months, even though you've discontinued the drug. For that reason, you also need to not give this drug concurrently with tamoxifen. So again, if you're thinking about where the drug is going to align with your other treatments, it's not in that space. So here's just their chart looking at the neutropenia. There's a lot less diarrhea, but there is some diarrhea here, and there's also fatigue. And again, dose modification is common, does not seem to dramatically affect the longer-term outcomes for patients who had substantial dosing, even if it was reduced a bit. So how do you choose an actual CDK4/6 inhibitor product? Well, the good news is you have choices. A lot of this is driven by the side effect profile, and in each of these studies, roughly 20% of the patients quit the therapy because of side effects. For the others, one chooses it, so patients who have liver disease, you would obviously avoid the ribociclib. Patients who want to minimize the diarrhea, you would probably avoid the abemaciclib, though anecdotally, some patients will tolerate one product fine and not the other. If you look at quality of life, reasonably well preserved over time, so that's not going to answer the question. It's a challenge in clinic. I confess that for intermediate risk, as I think we've already alluded to, I tend to use the Natalie regimen. For higher risk patients, I still give pride of place to the abemaciclib-based regimen for higher risk patients. But mostly it's finding a regimen that's tolerable for the patients, and also from the very beginning, benchmarking expectations, acknowledging that many of them may not finish the course of therapy. Most of them will probably have dose modifications or treatment delays along the way. I'm not going to get much into neoadjuvant endocrine therapy with this class of drugs. The fundamental problem with neoadjuvant endocrine therapy is we don't use it for long enough. You need to use it for about a year. So if you're talking to a patient who you're thinking, I want to give neoadjuvant endocrine therapy, you're probably talking about a year of treatment. And that's fine. It's an effective tool for many patients. But a lot of these studies are looking at a few weeks of treatment, and that doesn't really inform things very much. And the final point I'll close on is that we've talked a lot in the past 2 days about the interplay between some of the next generation oral SERDs and CDK4/6 inhibitors, and there's a lot of excitement about that. I think a worry is that all of the major adjuvant trials of of SERDs, the next wave of antiestrogens, do not uniformly include CDK4/6 inhibitor treatment. So paradoxically, the patients who you most will want to be able to know if there's an interplay between, benefit of these newer antiestrogen drugs are not in large part being simultaneously exposed to our CDK4/6 inhibitors. And so that's something that's going to be really important when we begin to think through the value of the SERDs when it relates to adjuvant therapy. I think that's the last slide. Oh, summary. So both have shown a lower risk of recurrence. They differ in side effect profiles. We don't know which is better. And I think it's important to stay tuned to the ongoing maturation of these data, which are being presented frequently at the meetings.
I've got like 50 questions, and this looks like my desk at home here. But Joyce, a couple quick HER2 questions. This afternoon, we're going to talk about TDXD in lung cancer, where it's used often first line with HER2 mutant disease. Sammy wants to know, have you seen any patients with a HER2 mutant breast cancer? Would you use TDXD there? Amy has a patient who's been on HP maintenance for 5 years. Do you ever consider stopping?
Good data, pan-tumor mutations in HER2. TDXD works across all of it. There's not an FDA approval yet, but there's good data. It's a pan-tumor, any HER2 mutation, except pancreas cancer wasn't that active, but otherwise looks good. So yes, I have, and I would. No, never stop. I know Dana-Farber is doing a trial where patients have been on the maintenance for a while, in a prospective manner are going to be looked at, but I've stopped it twice in my life. Both recurred, one after 14 years.
Wow.
And she came back in the same spot in the liver.
Wow.
And thankfully went right back into a CR, and she's on HP now for life. The other one, though, recurred diffuse and bone and died, so I will never do it again.
Wow, interesting. So again, faculty, it's been great to work with you. Mayan, thank you so much. We'll be back after this quick break.